So current statistics are that about 96% of all hospitals in the US use an electronic health record, and almost 90% of office-based providers in the US use an EHR. So this is the catch-22 when it comes to downtime. If one is lucky enough to work in an environment with a highly reliable system that experiences few unanticipated downtimes or disruptions, and the anticipated or planned ones are short, then clinicians and staff have very little to no experience or comfort level responding to the required workflow changes required when moving to paper. It creates anxiety, apprehension, and fear when all those familiar tools are suddenly unavailable. On the flip side, if one has the misfortune of working in a highly unreliable system environment, then staff tends to be more adept at reverting to paper and manual processes. However, we all know those frequent interruptions are certainly not the ideal state. Both scenarios, however, result in patient safety risk, with the greatest risk occurring as the systems go down and then they come back up. It's that pivoting that distracts direct caregivers and negatively impacts clinical decision-making. Next slide, please. So nursing practice is highly reliant on technology, systems, complex equipment, and equally complex practice processes and workflows. Nursing response to system interruption needs to be reflexive. It needs to be seamless, it needs to be practiced. And it needs to be similar to the way we respond to a code or to a fire drill. Downtime response is more effective when staff have repeated experience and exposure to downtime procedures, but outside of actual events. So today we hope to share some strategies to help achieve that reflexive response. And I would like to thank people for doing the survey. We'll share some of the results at the end of the presentation. And I have one correction. Syracuse is lovely, but I'm actually from St. Peter's Health Partners in Albany, New York. Thank you.
We got the state right? Sorry. All right. So here we are, how to safely provide patient care in downtime. Downtime preparation. Denise, I'm going to let you lead us off here.
So pre-COVID, we had two different groups. Both groups were very engaged, very active, amazing groups. We had one that was a multi-professional group for downtime, and another that was nursing, and some of our clinical informatics staff, that focused on our clinical system, and we called that group the ChartSmart team. The people remained active through COVID, but we were not meeting. When we decided to start meeting again, virtually now, we decided to combine the two groups. There was already crossover between them. They were excited to be able to help with both things. So that's where we are now. Lacey, what are you doing at CAWIA?
At CAWIA, currently our downtime experts are our clinical informaticists and our medical informatics team. We also have a nursing decision council where our directors are very involved in decisions around downtime. We have hopes to get it to the bedside, so we have them be our super users. The charge nurses and secretaries have been really the unofficial downtime experts, but currently the ones that know the most is the clinical informatics team.
And at our organization, rather than call them downtime readiness champions, we actually have a nursing informatics committee, which represents each inpatient unit has at least one representative, and we have representatives from some of the outpatient units also. Those members, the nursing informatics committee members, we really rely on them as technology experts, not just downtime. They basically do check the downtime computer at least once a month on the day that we have our monthly meeting. They also check the paper forms stock on the unit to make sure that we have the forms available for a downtime. They also prepare staff for all planned downtimes. Most of them actually email messages, job aids, different things to the staff that are working on the night of the downtime. And basically, as I said, they prepare the units and prepare the staff for all of the downtimes. Jen?
As part of our shared governance structure, we created a Clinical Informatics Ambassador Council that we coined CIA, and each nursing unit appointed one representation from their team that would best speak on behalf of their unit and could speak on behalf and lead that downtime effort. And their role was similar to my colleagues, that they were that downtime champion. They were responsible for knowing how to use the downtime computer, making sure everyone on the unit knew how to use the downtime computer, what the downtime forms were, any reports that we had on our computer, and they also helped with our downtime drills.
We had a recent EHR conversion, so we are in the process of standing up a new downtime readiness champion program. And it's not necessarily a clinician. We opted to identify staff who are the most familiar with the unit and the department workflow. Again, the initial phase is making sure that the downtime devices are up to date with reports and inventorying the downtime binders, and then we're going to move on to actually reinitiating drilling the staff on a quarterly basis.
And in terms of planning for those planned downtimes, so we have monthly planned downtimes for our network to get updated, keep on the latest version, take our patches, do any work we need to do on the switches. And we meet with our IT team, and we design what's going to go down, where the downtime is going to occur, what departments, what campuses will go down, and we come up with, is this realistic or not? So between 2 and 4 hours is the plan. About 2 weeks before the downtime, we have our IT director send out the list of everything going down. That gives people time to review the list and say, hey, what about this, at the leadership level. And then about a week before the downtime, the director of clinical informatics sends out a checklist of everything that is going down with the pre-steps, what to do during, and then post to the recovery. And that gives them an opportunity to make sure that they have pre-planning, so laptops, walkie-talkies are on the units, everything that they need.
To continue again, we're on the patient-centered prep for planned downtimes. Similar to what Lacey talked about, we do also have checklists. But before we get to the checklist, I just want to bring up that the time of the downtime is something that we've taken very seriously. We actually have an organizational guideline that we do not start our EHR downtimes until 15 minutes past the hour, because on the hour we have device integration, vital signs, meds, and different things that we want to be able to be able to do on the time that they're due. So we had made this general statement and guideline that all of our downtime start at 15 minutes after the hour. Planned downtimes for our EHR are always, of course, all of us do, if we have a choice, in a period of low activity. Again, we have a standard time. Our EHR is only allowed to go down planned-wise between 2:15 to 4:15 a.m. on a Saturday night into Sunday morning. Again, most of our downtimes have been 90 minutes or less, so it works in that period of time. If we need longer time, we negotiate with our ED, that of course is very busy until 2 a.m. So we kind of go back and forth with the ED and the house and decide if it's going to be 1, if it's going to be 1 to 4, if it's going to be 12 to 4, kind of we figure out what we need if we're going to plan a longer downtime. But definitely something to think about when we're thinking of a patient-centered experience. Back to the checklist. We have a checklist that actually goes for the bedside nurse as well as the charge nurse. For the bedside nurse, we ask them to, again, this is the shift, the staff that are on shift, previously or right before during the downtime. Check their patient orders, call for any orders that are needed that they might need during the downtime that they can anticipate that the patient might need. Again, check the EHR and make sure that the documentation is up to date before we go down. Again, print the downtime reports, gather the patient, the papers, the patient care flow sheets, and place patient labels on them. So get things ready for the bedside. Check the shadow system when we go down to make sure that some physician didn't or provider didn't put an order in real quick before the system went down that the nurses weren't aware of. Again, our downtime reports are usually up to an hour old. So again, making sure that something didn't happen since the reports were printed, again, checking our shadow system.